and welcome to the Cancer Research UK Cambridge Centre podcast, The Future of Radiotherapy series. This series is brought to you by the CRUK RadNet Cambridge programme in partnership with our lovely Patient and Public Involvement and Engagement Group. Hello and welcome to today's episode. I'm joined by David and Amy to talk about FLASH radiotherapy. So we're going to find out what this is and how the introduction of FLASH can impact treatment. For this series, we always get one of our patient representatives here to ask the questions that you would want to know about and to discuss the perspective of our patients and the public when considering new research. So first of all, let me introduce David Fernandez-Antoran, who's the lead of the Laboratory of Radiation Biology and Cell Competition at the Gurdon Institute in the University of Cambridge. He's the co-chair of FLASH Radiotherapy Working Group in the UK, and his laboratory studies how tissues respond to radiotherapy treatments. This is not only tumours, but also normal healthy tissues in order to develop more effective tumour-killing radiotherapy and less aggressive with the healthy surrounding tissues.
Hello.
And we have Amy, one of our patient representatives from our RadNet Patient and Public Involvement Group. She's recently had treatment for cancer behind the left face, so the salivary gland, which is next to the pharynx. And this tumour was removed by surgery, and she had some radiotherapy to reduce the chance of relapse. Thank you so much for joining me today. David, could we find out a little bit more by what we mean by FLASH and what FLASH radiotherapy is?
So basically, when we talk about FLASH, we're talking about the dose radiotherapy is working. We basically have conventional radiotherapy, which is in the normal doses of radiotherapy. We don't have to talk about numbers, but just to give you a kind of idea. So if we talk about 2-3 units per minute, which is conventional radiotherapy, here we are talking about 1,000 units per second. So you can imagine the difference between FLASH and conventional. And basically FLASH is called, because of that, is called ultra high dose radiotherapy. It's been working in FLASH, to be honest, since the late 50s. So it's not something really, really new. The fact is that they found that when they were posing very simple organisms like bacteria to really high doses of radiotherapy, or in this case, ionizing radiation, which is basically what radiotherapy means, they saw that the bacteria were less damaged compared to being exposed to normal conventional doses of ionizing radiation. So they were starting looking at this, let's say, phenomenon. And then they found that it was a matter of depleting oxygen in the tissues, or basically in the organism. So in 2019, it was the first patient and the only patient treated so far with FLASH radiotherapy. And basically, it was a T-cell cutaneous lymphoma patient. And they were able to cure the patient with the radiotherapy, with FLASH. And the most interesting thing was that they found that FLASH was basically killing the tumor in the same way normal radiotherapy was able to kill the tumor. But let's say the advantage of this FLASH treatment was that the FLASH radiotherapy was not affecting much the normal tissue, the surrounding healthy tissue, which usually in conventional radiotherapy treatments is provoking the typical, say, side effect or toxic effect of radiotherapy. So this is basically what I can tell you, just an introduction about what FLASH means.
Brilliant, thank you. And my sort of understanding was we have quite a long way to go with FLASH research, but from what you've just said, it's been around for quite a long time. So what sort of treatments could be impacted by the introduction of FLASH, or is it too early to tell?
A bit early to tell, that's true. But just to clarify, so it's been known, the FLASH effect, which is called the FLASH effect, it's been known since the 60s, but it's only been applied or more interested to be applied in radiotherapy treatments since early years. So it's quite novelty in terms of people looking at this as a proper radiotherapy treatment compared to the conventional ones. So basically, one of the main advantages of FLASH is that we can deliver huge amount of radiation to kill the tumor, which is basically the purpose of radiotherapy. But we can reduce a lot the normal tissue toxicity. And that's because we reduce a lot the time the cells or the tissue is exposed to radiation. We're talking about milliseconds. So basically for the patient will be a great improvement in terms of spending time in the clinic to be exposed to radiotherapy. So that would be a great improvement in radiotherapy treatments. The thing is, we still are a bit far from using FLASH as a proper radiotherapy treatment because we are still at the, let's say, the beginning of understanding how FLASH works. Because there are several theories, there are several hypotheses how FLASH radiotherapy works in these tissues and how we are killing tumor but not affecting normal cells. And one of the theories is about how oxygen works in all this phenomenon. But there is still lots of experiments and discussion about these theories. So we are in the lab heavily involved in these FLASH studies. We're trying to understand how FLASH is affecting patient tissues in culture, in vitro. And we have some really interesting results. Actually, yesterday we got them. So basically, we're trying to find the way of saying, okay, FLASH is working in this way, and then applying that to the patient in a more safe way. Another issue with FLASH is also that the equipment, as you can imagine, to deliver such a huge dose of radiation is really expensive and difficult to have. So there are not many places in the UK, especially with FLASH technology. And those who have it, they only use for research. So it's not yet in the clinical practice. So yeah, so you answered your question. Sorry for being so long in my answer. So basically, we are still far. We are still quite far to be able to implement this radiotherapy technique in the clinic. Yes.
Thank you for such a great explanation. So this leads me on a little bit to introduce Amy. Hi, Amy. So Amy, do you want to just tell us a little bit more about your experience of radiotherapy and the treatment you received a little bit?
Yes, so my radiotherapy followed surgery quite quickly afterwards, actually. And it lasted for 6 full weeks. So Monday to Fridays, like going to work, pretty much, not 9 to 5, but yeah, I needed to commit myself to 6 weeks going to the radiotherapy department. And throughout those 30 days, the first 1 or 2 weeks were kind of okay. I even felt completely normal after the first few days. And I thought, oh, that is quite easy. And then by the time it was week number 4, like just halfway through the treatment, it started to feel like a struggle, even though I got support from my family to take me to the hospital. And then by the last few days, it's really, really dragging my feet to the radiotherapy department. I don't know if it's like someone running a marathon, you're almost at the finishing line, you just need to push through. But, that is for a medal. I don't get a medal at the end of it. I just wanted to get it all done with. So that was quite tough. And during that time, those 6 weeks, the side effects, because of the toxicity to the healthy tissue, like what David was talking about, the toxicity, the damage was just building up, and it was getting more and more difficult with my daily lives. I found it really difficult to swallow, to talk, even to swallow saliva. I'm not even talking about eating. Eating and drinking was a big problem. Very, very tired. So loads of side effects, very acute. And those side effects basically lasted for another few months after the treatment finished. So it was really challenging. I knew it was necessary to save my life, to reduce the chance that the cancer might come back, but it was definitely not something I would like to go through ever again with that particular technology. And that's why I'm very interested in listening to David talking about this new technology. Still early days, but sounds like huge potential to reduce the suffering of many patients.
Definitely, you face quite a few challenges with the side effects of your treatment, and I guess, David, what you could look at, like you've mentioned, is if FLASH radiotherapy could help those challenges, similar to what Amy's had, in a way of reducing those toxicities, like you mentioned, with being able to deliver treatment a lot more quickly with the machines, in very basic term. So I'm guessing that's sort of the long-term aim, is to help with some of those challenges that Amy's had.
Absolutely. That's the idea. So basically, conventional radiotherapy main issues, what Amy is mentioning, so the toxicity in the normal tissues. Although nowadays we are able to focus the beam of radiation quite narrow into the tumor, we always expose some bit of normal tissue to different levels of radiotherapy. And this is what is creating the toxicity, mostly, basically. The main advantage of FLASH is as you mentioned, is the how quick we are delivering this dose. So basically also it's quite important for patients to be really say quiet also, but they are receiving radiotherapy. In the case of FLASH, because we do this radiation quite quick in the order of milliseconds, it's very easy to target essentially the tumor part without having any vibration, which can affect the normal tissue. So that will also improve the normal tissue toxicity we could see. The thing is, there are several ways in which we can improve the delivery of FLASH in the clinic, but the main issue we have here is that we still don't know how FLASH work in the long term, for example. So we know we are affecting the tissues in the way that we can kill the tumor, which basically more or less the same capabilities as conventional radiotherapy, but we don't know yet what are the let's say the long-term effects in the normal tissue after FLASH. We know already very well after conventional. So at the beginning, we have seen that there are not apparently not many or not at all any toxicity in the normal tissues, but this is very early to say. That's why we are now trying to find out a bit more to see what are these effects. But basically, I truly believe that if we are able to implement FLASH in the clinic, it would be a great advantage for many patients receiving radiotherapy, because just basically reducing the time you guys spend then during the treatment, it will be a huge advantage, for you. And on top of that, if we can kill a tumor easily, quicker, without any pain, I think, well, of course, minimizing the pain at all, at maximum, it would be great. So yeah, I think it would help a lot of patients as Amy. Yeah.
Thank you. So Amy, have you got some questions for David?
Yes, I'm just listening with great interest about this millisecond administration of radiation to kill the tumor, because I just talked about these 30 days that I had to go to the clinic every day. And I also heard some other people were suffering from cancer. Those 30 days is not just very tiring, very difficult. They also had other schedules to commit to, for example, childcare, or they need to care for elderly parents, like really difficult situations. So I just wonder, I know it's still early days, but perhaps maybe not 30 days of treatment, maybe just go there for 1 week, just cut it down. That would be a massive reduction, from 6 weeks to 1 week. And that would just free up people's time to do other important things in their lives. Is that a possibility, David?
Yes, that is the final aim. Actually, if I'm honest, in an ideal world would be just one single dose of radiotherapy to kill the tumor. But of course, this is a very early stage for me to say that. But this is the main thing, because if we are able to deliver such a huge dose and we are able to kill the tumor cells immediately with this radiotherapy treatment, that would be more than enough for the patient, to get rid of the tumor and actually even get less toxic effects on the normal tissue. But of course, this is just a very realistic assumption I'm saying here. So we have seen so far in some of the preclinical experiments we're doing in the lab how FLASH is affecting normal tissues in vitro. So human tissues, we work with human tissue, primary human tissues from donors and patients. And we do see that, of course, because this is radiation, so we are able to affect cells, normal cells. So we need to be very careful, okay, and to work, with this to understand how this new technology is working and how we can control. I don't want to go into detail, but basically you might know that there are several types of radiotherapy. There is not only one type of radiotherapy. We can deliver protons, we can deliver X-rays, we can deliver different things, right? And on FLASH, we can do the same as well. We can do FLASH for protons, we can do FLASH for electrons, and each of them have advantages and also disadvantages, as you may know, as everything in the life. So basically, we're trying now to understand how differential FLASH technologies like protons, electrons can work, and in which in which way they damage, the cancer and the cancer cells and not the normal cells, but also how easy will be to implement these FLASH special technologies in the clinic, helping patients. I mean, for example, patients with a very superficial tumors will be easy to do radiotherapy with electrons because the penetrance is very low, so they can just basically hit the top of the tumor, so they will kill easily, for example, skin tumors in the superficial area. However, for more deeper tumors, but also quite difficult to access, proton therapy is the most convenient one. And actually nowadays, conventional proton therapy is working really well in, for example, in patients with brain tumors, where you have the tissue that is quite sensitive around the tumor, and you don't want to affect much the normal tissue. So FLASH proton therapy is also really promising because we should be able to do huge dose in the tumor inside the cavity without affecting the surrounding area. So there is plenty of studies now going on. We have a huge commitment with University of Oxford and Manchester to trying to find out more interesting facts about FLASH. So I really hope that in few, let's say in a year or so, we will have some interesting results to show to the public to see that this is a really promising technology that we can apply into the clinic.
Thank you, David. It's interesting you mentioned protons because our last episode, which Amy joined us for as well, was talking about proton beam therapy. So that's really nice to hear that actually the two, what's been developing now and obviously what's still in sort of preclinical, but where that's sort of heading, it's really interesting to hear. I have a quick question, if it's okay. With, like you say, being able to reduce the number of treatments per day, like Amy was saying, can we go from like 30 to a week, or even, like you said, one day? So just for the listeners, there's a word that we call that. It's called hyperfractionation. So that means that we reduce the number of times that you come, but it's usually a higher dose per day. And the extreme version to that is having one really high dose, sometimes what they call a stereotactic dose, in one go. So what my question is that with the use of FLASH radiotherapy, we're going to also need the more introduction of something called adaptive radiotherapy. So that's a case of plan of the day. So rather than having, so Amy, just to explain, is that plan of the day is where you have your CT scan on your, like what you did when you have your mask made and you come for your planning scan. And then each day when they do a scan to check that you're in the right place, they are able to almost replan at the same time and recalculate the dose based on where you are on your specific day. And that's sort of been in the development for many years, but it's still kind of getting there. So what I'm thinking is with FLASH, you're going to have more of a need for adaptive radiotherapy. Do you think, David?
That's a good question, but if I'm honest, I have no idea. That's my real answer. Okay, but if you ask me if I can guess about that, so basically the idea, if we think about if we want to reduce the length of the treatment with FLASH, because we are able to kill the tumor faster than conventional, which is still not proved. Okay, so we are still under the studying how it works. So the idea would be, of course, to deliver less doses per week. For example, imagine instead of Monday to Friday, we have once a week in four weeks, and we can. So of course, what you mentioned, it would be much easier to apply. We can do CTs, the week before, or the Friday before, next Monday, and then you can plan in advance the treatment. But this is a lot to say from me, to be honest.
That's fair enough. I think I was reaching quite far there, wasn't I? Amy, did you have another question?
Yes, I realized there is something that is always on my mind about more long-term side effects from radiotherapy. So of course I suffered from, dry mouth and very crazily sticky saliva and not being able to eat and all sorts of problems during radiotherapy. But if worst comes to worst, it's just almost like time limited, right? 6 weeks and then maybe a few months afterwards. But of course, I also live with lifelong side effects. For example, because of the amount of radiation my skin received during that treatment, I need to be very careful about the sun. like with this recent sunny weather, everybody's enjoying that. I have second thoughts about that because of what I heard about the proton beam therapy that's coming up, the PBT, and also now with FLASH. Both of them have promises of reducing side effects, reducing toxicity to healthy tissues. So I just wondered, in the context of more long-term or lifelong side effects that many of us are living with right now, is there any chance that FLASH may be able to reduce that? Maybe not complete, eliminating that, but is there a chance to, maybe minimize that?
Yes, so basically in the only clinical trial of treatment we have seen with a patient, we saw very little toxicity in the normal tissue. We did see some toxicity, of course, but compared to conventional radiotherapy, it was minimal. So basically, based on that, which is just single, number one, we expect to have a huge reduction in the toxicity into the normal tissue, even long-term responses after radiotherapy. So we are basically understanding this long-term because we are focused to understand what is the quick or the rapid effect of FLASH in tissues, both in the tumor and in the normal cells. But also more important regarding your question is what happened at after 2 months, 3 months, 1 year after you receive the radiotherapy, the long-term responses of supposedly the tumor is gone, but we have the normal tissue with being exposed to this radiotherapy. And in your case, you might be suffering for these long-term responses and long-term toxicity. But the idea is that FLASH should be able to minimize that toxicity. But we still need to see because we don't have enough number of studies to show. Because in the other side, it's also I need to be clear here. We have seen some other studies using animal models, for example. Many of them have shown really, really promising results in terms of how FLASH works, how FLASH is able to kill or reduce the tumor size. But some of them have shown also no differences with conventional radiotherapy. We're still trying to find out whether it's because of the experimental conditions or the type of tumors, or the way they deliver the radiation. But there are some other studies, not are the most of them, but some of them have shown no differences with FLASH. So we're trying now to understand what are the causes because those studies were not showing these great advantages. But basically, one of the main interests about FLASH is also avoiding long-term toxicity of the normal tissue. And this is what we are trying to find out if we can have that. Yeah.
Thank you. So I guess we've kind of covered how it really changes the day-to-day. So we could potentially have people come through and not have to spend as long in the radiotherapy department, not as long in the clinic, and not as long in terms of treatment duration. So that's sort of how it would change the day-to-day standard of practice of radiotherapy. Is there anything else that could maybe change the day-to-day of radiotherapy with FLASH at all, David?
Yes, absolutely. So basically, given the short pulses of radiation we are delivering, as I mentioned before, the time the patient is actually supposed to spend into the room in the treatment, it would be reduced hugely because we are delivering 90 milliseconds of radiation. So we don't have to be exposed for such a long time under the radiator. That would be one of the main advantages. I know from people I know before being exposed to radiotherapy, depending on some type of tissue, they need to have this kind of armor, to maintain the head and the body really still. And I know people that are really feels anxiety because of these type of things. They need to stay for a while. With FLASH, ideally, it would be, if not necessary, maybe it will reduce the amount of time we have to put the patient in this situation, which would be a huge improvement in terms of the treatment.
Thank you. Yeah, I agree. We get a lot of people, especially my experience in the pre-treatment. So when people come for their planning scan, there's a lot of anxiety with the masks and the masks being made. I would think that we'd need to think about the materials that we make it with, especially if it's been delivered that quickly. But if they're on for a lot less of the time, I know, Amy, you had a mask made for your treatment. If it's on for a lot less of the time, we could potentially reduce that anxieties. Amy, do you have anything to add?
Yes, because when David mentioned about being still inside that machine, whatever the machine is called, in my case, for about 2 to 3 minutes, not very long. And it wasn't difficult just to lie down for that period of time. What became difficult in my case for a head and neck cancer was, I think, towards maybe the week 4 or onwards, because my throat was so damaged. I sometimes felt really itchy. I mean, it was really itchy, and I felt like I wanted to cough, but I knew I should not move because the radiation is actually targeting that kind of area. Any slight movement, that radiation would just go astray, right? So it was so difficult not to cough, like to cough or not to cough. That was the question. So if in the case of FLASH, when it's just like, boom, did you say 90 milliseconds, David? I think I could live with that. Within 90 milliseconds, probably I would not have the urge to cough. And that will be so much easier because it's just something always at the back of my mind, like hold it, right? It's nearly done, don't cough. And yeah, I think for other patients maybe suffering from head and neck cancers with a similar experience, that will be a big relief.
I agree, Amy. And as well, like those that have lung cancer tumors as well, which one of their symptoms is like a cough or things like that, that's in the back of their mind as well, like to cough or not to cough. So yeah, I definitely agree. Something that's delivering that quick, and there's lots of other considerations of how to keep people still and probably a lot of other things in the future. But yeah, it's interesting to hear that for now of where the delivery of treatment could go. To sort of wrap up, I guess the main question is, David, is where do you see FLASH radiotherapy being in the next 5 to 10 years? Perhaps a tricky question, maybe.
It is indeed, it is. So I will expect, at least to have the first preclinical treatments in place by, let's say, 10 years. I will say 10 years. When I mean clinical trials, I meant proper clinical trials with more patients, and having a really well support based on preclinical data on animal models and in vitro, which we are now working on. So I truly expect that by 5, 10 years, we should start seeing more clinical trials that will allow us to say, for sure, this is FLASH, this is how FLASH works, and this is the way we can improve treatment in the clinic.
Brilliant, thank you. Is there anything, Amy, you would like to see in the next 5 to 10 years based on what David has said?
I think what I sensed is a lot of hope. If we talk about 5 to 10 years, I will be in my 50s when cancers are more likely, because you tend to get more cancers when you get older. Having gone through the experience once, I don't want a second one, but if I do get one, let's say like breast cancer, which is quite common in the female population, I feel less scared because whatever treatment will be available then must be much better than what I experienced, much more advanced, a lot more, I won't say comfortable, but less suffering in general. And looking at, let's say, my friends or my friends' children, people in my family, if, touch wood, if they get cancer, I also feel more hopeful. Catch it early. And we have all these new treatments coming along. Okay, not helping people who are suffering right now, but yes, for the future, I'm definitely seeing more hope.
I think that's what most of our research is looking towards, is just hope, isn't it? Hope that we can just make things even just a little bit better every single time, just sort of looking to the future. So I think that's a nice way to wrap up, I think. David, do you agree?
Absolutely. I just want to say that it's been a real pleasure to meet Amy and hear her story, which is really impressive. And I really like, listening patients, because this is the way you keep, coming every day to work thinking, okay, this is going to be cool. This is going to be good for people's lives. So I really appreciate your time.
And also thanks to David. That's why we have hope, right?
Exactly. What would we do without you, David, eh? Thank you very much for joining us, and we'll hope to see you in the next episode.